a T2, and see there's sort of an ulcerating mass here, as well as more of an exophytic mass in the vagina. It's involving the lower third of the vagina. This one kind of extends up a little bit higher to the mid-third. And it's sort of intermediate to mildly hyperintense on here. Go to the T1. Here's T1, it's pre-contrast. And you see part of that mass has T1, intrinsic T1 signal. Down here, it's harder to appreciate the more exophytic portion of the mass, but it's here. It's not really that bright. So this may be blood products, or it could be melanin, which in this case it ended up being a melanoma. And I can show you the post-contrast as well. Yeah. Here's the post-contrast. So some of this is sort of a large ulcerated mass, and there's also an exophytic component coming off here. So this part did not have as much T1 signals, whereas this area did. So again, it might be melanin, or it might be some hemorrhage within it. So basically, it ended up being melanoma. Primary site was the lower vagina, and that's actually, one of the malignancies that can occur within the vagina. And the most common that we always think of is squamous cell, and then next would be like adenocarcinoma. But melanoma can occur in about up to 2% of patients. Typically, when it does occur in the vagina, it's in the lower third. Oftentimes you'll see it, since melanin is bright on pre-T1, usually they'll be bright on pre-contrast T1. You can have amelanotic melanoma as well. So just because it doesn't have the pre-T1 hyperintense signal doesn't mean you should completely exclude melanoma. And then also they tend to ulcerate often and can have hemorrhage. So in this case, I believe that area, part of that might have been hemorrhage. And it was more of an amelanotic melanoma, and some of that may be hemorrhage since it's ulcerating here as well. But other things that ulcerate, the main thing you would want to think of is squamous cell, because that typically ulcerates pretty significantly as well. But this case, it was melanoma. It's biopsy proven and everything. More commonly, melanoma will occur in the vulva as opposed to the vagina, or vulva more than the vagina. So it's also something to consider. But this one, they said it was coming off the vagina. And then,
areas. Okay, sorry. Go ahead.
Oh no, you're good. What
the areas that aren't T1 hyperintense, are those the amelanonic component?
Yeah, so you can often have mixed as well. So some parts can be melanotic and some parts can be amelanotic. And so this part was not T1 hyperintense, and it had a little bit more T2 hyperintense signal. So this part was more of an amelanotic melanoma. Yeah, and I think this part they were thinking was more hemorrhage. The T1 hyperintense area, but it certainly could have had a little bit of a melanotic component as well. It's hard to sort of completely differentiate. And then just for drainage pattern, I think there were a couple of lymph nodes that were a little prominent, not that significantly enlarged, but typically the lower third of the vagina will drain into the inguinal lymph nodes, and the upper third or upper to mid third will go more towards the external, internal obturator regions. And then the posterior, which is less common location for melanoma. Typically melanoma will be anterior or anterolateral, but the posterior, if it was in the posterior, that sometimes kind of follows the lymphatics of the rectum, and will often go into the internal and iliac lymph node drainage pattern. So yeah, just a little bit about vaginal drainage pattern and then melanoma as well. So
did you know if they thought it looked atypical on health exam?
I think it still had some melanoma, it had some of that melanotic component. It's just, I don't know, I think it was biopsied outside, so I don't know the full detail of it, yeah.